Good morning, everybody. Thank you, as always, for joining us this morning. As always, just giving it a moment for everybody to hop in online today. Hope everybody's having a good week so far. We have, I often say this, and I really mean it today as well. We have a great setup today for Grand Rounds. We've been planning this for quite some time. We actually have 5 presenters today in a mix of a presentation / if we have enough time, hopefully a good panel discussion with questions from you to talk about behavioral health services that we offer at Stanford. We have amazing behavioral health services. I want to first turn it over to Dr. Dunn. Dr. Dunn, I'll turn over to you just some brief updates regarding some awards, the diversity awards. Thanks.
Good morning, everyone. Welcome to Grand Rounds this morning. I'll make it nice and brief so we can get to our speakers. I do want to just acknowledge the excellent medicine turnout for yesterday's rally for reproductive rights. It was wonderful to see so many people out there for women and people who can get pregnant in light of the recent news. We will all keep fighting and advocating. I did want to also announce that the Chair Diversity Awards application portal is open. And I know originally the deadline was rapidly approaching, but we are going to extend the deadline to July 15th. So I encourage anyone to apply. Remember, this is open to instructors and assistant professors. And really the aim of these is to advance equity and inclusion in every aspect of human diversity. So we really would like to see you all put some projects out there. We want to give this money away, and we appreciate Bob's support of these types of awards and these seed grants. So I'll put the link in the chat to apply. Thanks so much, and I'll send it back to Dr. Ozdalga.
Thank you, Dr. Dunn, and thank you for mentioning the rally this past Monday. Obviously, we've had a big announcement since our last Grand Rounds. I just want to mention as well that we are planning to have Grand Rounds that addresses. We've been planning this for a while. So July 13th as well as July 20th, we have a Grand Rounds. We'll have a 2-part session that addresses reproductive rights. We actually were able to open up the 13th, so we actually don't have the exact details for that one yet. But we just were able to open that yesterday, so we're going to have that be on this topic. The 20th, we had actually planned for Bernadette Myler, a doctor of law. She's going to be talking. She's actually one of our top lawyers in this space at Stanford. She's going to be talking about the new recent decision from a legal perspective. Our other part of the series will look through it through another lens as well. So looking forward to that. Please join us for that. By the way, speaking of kind of big events going on in the country, the July 27th, we'll also have a topic covering gun violence as well. So we'll send more out to you to promote those events. Also want to mention next week, we have our Grand Rounds, which is involving Brian Brady. Brian Brady will be talking from value-based care, nephrology's opportunity to lead change. He was initially going to be presenting in person, as we often try to do at the beginning of the month. Just like we did in June, we will be canceling the in-person aspect of Zoom, so of Grand Rounds, so we'll be only on Zoom. So please don't show up to the medical school, because we'll keep everything online. But today we have a really great group of colleagues presenting. Perhaps some of you may have remembered earlier this year, we had Dr. Craven, along with Dr. Linda Nguyen, present from a health perspective, from a behavioral health perspective, about the what we offer through our gastroenterology division. And actually, it was Dr. Harrington and Kathy Garzio after the session had mentioned, it'd be great. We have a really amazing group of behavioral health psychologists at Stanford, which I'm interested to learn more about how unique this is. I have a feeling we're somewhat unique relative to other institutions to offer this really great service. And I know personally, this is a wonderful, wonderful thing that we have. And we wanted to make sure that all our clinicians are aware of it and we can really utilize these services. So we have them here with us today. They had kindly offered to somewhat introduce themselves as we have 5 speakers as they come up, but I do want to briefly acknowledge all of them. So we have with us today from Sleep Health Division, Dr. Fiona Barwick. She's a clinical associate professor and an associate division chief for behavioral sleep medicine. Within our chronic pain division, we have Dr. Heather Poupore-King. She's a clinical associate professor and director of the Pain Psychology Fellowship. Within digestive health, again, we have Dr. Meredith Craven, clinical assistant professor and director of GI Health Psychology. We have it within digestive health as well, Dr. Monty Tanenbaum, clinical assistant professor, and also within division of endocrine, division of endocrine gerontology and metabolism. And finally, from cardiovascular health, Dr. Katharine Sears Edwards. She's a clinical assistant professor for cardiovascular medicine, and by affiliate by courtesy, psychiatry and behavioral sciences as well. So doctors, thank you so much for being here today. I was briefly mentioning to you all before, and I think a lot of clinicians will acknowledge this. Probably a huge percent. I know as a hospitalist, I would say 90% of all my patients at some point, whether it was years ago or recently, have some sort of mental, psychological perspective or behavioral aspect that ultimately triggered their health decline or something that got them to be hospitalized in the first place. And I think all of our clinicians will note that this is so important to us and so perhaps undervalued. And so we're so lucky to have you all here. I'm going to turn it over now to you all in the slides. And thank you so much for being here. I want to mention the goal of this initially was to be more of a panel discussion, but the doctors wanted also to make sure they're sharing individually what each of their sections really do. So they're going to have some introductory slides and then maybe talk for about 5 to 6 minutes each. So our goal is to get through this, once we get through this, to make sure we have as much time as possible for your questions, but we'll of course never have enough time for all the questions. So please ask your questions as soon as you have them and vote them up so we can get to the most important ones. We do have a hard stop right at 9 o'clock because all the doctors have patients right at 9 o'clock. So we're going to stop then. I'll turn it over to you all. Thank you so much for being here.
Thanks so much, Dr. Zalga, for the introduction and for the invitation to speak. We are all very excited to share what we do as far as health psychology services here at Stanford. None of my, let me make sure, hold on a minute. Sometimes this doesn't advance the way I want it to. There we go. None of my presenters nor myself have any relevant conflicts of interest to disclose. We want to start off by framing our discussion today in terms of the biopsychosocial model, which is the model from which we all work. It's a little different than the biomedical model. Both the biomedical model and the biopsychosocial model obviously share an interest in biological factors, things like genetics, disease and injury, individual differences in pain sensitivity or stress response. Obviously, these are going to impact any condition that people have, but the biopsychosocial model adds the psychological component and the social component as important parts of addressing any chronic condition. So psychological factors include things like anxiety or depression or past experience of trauma, all of which can impact how someone experiences or the symptoms they have with a condition. How people respond interpersonally to the condition, whether they're using substances, can have an effect. And socially, things like whether or not we're able to continue working, the cultural context in which the condition unfolds, any stigma attached to it, any support or lack thereof from family or friends, all of these impact how people experience and how they respond to treatment for whatever condition they might be having. So this is very much the framework we use for any patient we see. This biopsychosocial model rests on this fundamental interconnection between what we think, how we feel, what we do, and our physiology. Because these are all interconnected, if we change any one of these things, we can actually affect change in all the others. So literally, if we help our patients think about their condition differently, if we help give them a better understanding of the condition, a clearer sense of control, a greater sense of self-efficacy, that is guaranteed to change how they feel about it, what they do about it, and the state of tension in their body. So we all work from this mind-body connection. Katie, I think you were going to talk about this.
Yeah. So more about the mind-body connection. This is some of what we understand about the actual pathways of influence in terms of how psychological comorbidities can affect our patients. In cardiology, we have a lot of comorbidity. For example, cardiac patients actually have an incidence of depression that's almost twice that of the general population. And our depressed patients, they don't do as well after surgery, after heart attacks. They have more recurrent events, and unfortunately, even higher rates of death within 5 years. So these pathways are really important to understand. And this is where the treatment comes in. So not only the biological direct pathways, and this list is certainly not exhaustive, these are things like the increased sympathetic tone, decreased vagal tone, and overactivity of stress hormones that can influence disease process, but also the indirect behavioral pathways. So the emotional and behavioral responses that can impact health behaviors, such as non-adherence to medications, inactivity, disinterest in self-care, poor diet, overeating, and substance use. So this is a general model for interdisciplinary care, acknowledging that for us to holistically care for patients when they're recovering from disease or managing chronic illness, that there are contributions from a variety of different providers that can help with this holistic model. Medical services, of course, allied health services like PT, OT, RT, social work, and also psychology to help patients resume their psychosocial functioning in the world. So in health psychology, we aim to implement a stepped care model. A stepped care model allows us to care for as many patients as possible, depending on the level of need for the particular individual. We usually start off with some kind of a self-help intervention, bibliotherapy, education, inviting patients to support groups, and teaching them a few self-management skills. Beyond that, we often refer patients to groups, which is a great way to reach more patients and teach more specific skills. Then we move patients on to individual treatment, or in some cases, when they're not appropriate for groups, we'll treat them individually at first. And Fiona will talk a little bit about the other two tiers.
Depending on our area of expertise, we can offer augmentation therapies. I know a couple of my colleagues, Dr. Edwards, Dr. King, offer biofeedback. Here at the Sleep Center, we do melatonin testing and actigraphy to help identify circadian rhythm disorders. And then sometimes it is the case that as much as we want to help our patients get better in whatever area we're focusing on, there are other things that are interfering. Trauma is a common one. It can make it difficult for people to engage in therapy. And so we will make specific referrals to outside therapies where appropriate. I'm starting off the individual parts of the presentation today by talking about behavioral sleep medicine. These are some of my wonderful colleagues and fellows and technologists and administrative staff. I focus on behavioral sleep medicine, which addresses the evaluation and treatment of sleep disorders by focusing on these behavioral, psychological, and physiological factors that interfere with sleep. Behavioral sleep medicine treats a variety of sleep disorders, not just insomnia, but hypersomnia, nightmares, circadian rhythm disorders, PAP exposure and adjustment, pediatric sleep problems like night terrors and enuresis, and sleep aid cessation, of course. Now, I didn't include any psychiatric disorders or medical conditions, but the reality is sleep is disrupted in every psychiatric disorder and many chronic medical conditions. And research is very clear that what we use to help with problems like insomnia or hypersomnia can actually help other conditions, anxiety, nightmares and trauma, depression, even things like Parkinson's disease, cancer, multiple sclerosis. The research has shown that cognitive behavioral therapy for insomnia, which is a subset of behavioral sleep medicine, is effective in helping improve sleep in these conditions. And even though improving sleep is not going to cure the condition, it is going to certainly help people manage their symptoms more successfully, and it's going to help them improve their quality of life, which for some of these conditions that are incurable is really, really important. There are three targets for behavioral sleep medicine that we focus on with each patient. So the first is the circadian system, those 24-hour fluctuations in our biological rhythms driven by a central pacemaker in our brain. They govern, frankly, most of our behavior and physiology. Sleep-wake is the biggest and most obvious circadian rhythm. One of the first things we want to do is try to identify what a patient's sleep-wake circadian rhythm is, their chronotype or the timing of their sleep, and we want them sleeping in or as close to that window as possible, because people will get their best sleep in their biologically optimal window. We also want to encourage them to use light-dark exposure strategically. Unfortunately, nowadays in our modern world, it's totally reversed. People are indoors all day and on their screens all night. That's not what it's supposed to look like. So we definitely encourage people to get more daylight exposure during the day, especially in the morning when our body clock resyncs to our 24-hour environment. That morning rise time is probably the most important part of keeping sleep-wake rhythms on track. Conversely, we want people limiting or minimizing their screen time at night in that hour or two before bedtime when melatonin typically goes up. This is especially challenging given the digital dopamine addiction that everyone is experiencing nowadays and how hard it is to get off their screens. We also want to encourage people to be consistent with their rhythms. Consistency is an important part of the circadian system. The more consistent we can be, the more our brain and body learn to anticipate what we're doing and actually help us with that process, make it more effortless. And finally, although sleep-wake is our biggest circadian rhythm, it's not the only one. Feeding, fasting, rest, activity, or other circadian rhythms, and we tend to feel best and function best when our circadian rhythms are aligned. This is especially challenging because although sleep-wake rhythms are driven by the central pacemaker in the brain, which is most responsive to light-dark cues, there are peripheral oscillators in pretty much every cell, tissue, and organ system in the body, and some of these oscillators, like those in the liver or the stomach, are more sensitive to food cues. So you can put yourself in a state of internal circadian misalignment if you are sleeping and waking at one time and then eating at another time. So we try to help people line up their circadian rhythms. The second system we focus on is our sleep drive, a biological drive that builds as we're awake and active and comes down as we sleep. We help people understand that you can inadvertently weaken your sleep drive by napping during the day or dozing before bedtime. So we help them understand how to use napping strategically, less than 30 minutes, 7 to 9 hours before your bedtime. We help them use movement to refrain from dozing at night. And we also help them to understand how to increase sleep drive. First, by staying awake longer. Pretty much everyone we see is spending more time in bed than they can fill with sleep, at least when it comes to insomnia. That actually weakens their sleep drive, so we help them understand that. Sleep drive is also built with physical activity, social activity, daylight exposure. So we try to encourage them to re-engage with some of these things if they are doing less of them than would be helpful. And finally, we focus on the stress response. Part of getting better sleep is actually managing stress more effectively. Stress always disrupts sleep. And so having a calm mind, a relaxed body before you get into bed, if you wake up at night, is going to be better for sleep. So we encourage people to build a buffer zone between their day and their nighttime so they can decompress after the day. We encourage them not to check the time at night. We teach them relaxation strategies. Now, none of these things guarantee you're going to sleep because, quite frankly, nothing guarantees sleep except being awake long enough. But if these things are in place, it is likely your sleep will unfold because we tend to sleep better when we feel safe and comfortable and relaxed and loved. Now, the evidence base, I do want to mention this one thing. Cognitive behavioral therapy for insomnia is different than sleep hygiene. These are often confused. Sleep hygiene are factors like keep your bedroom dark, cool, and quiet. Don't eat or exercise close to bedtime. Don't have caffeine or alcohol close to bedtime. So if you have good sleep, your good sleep hygiene will support that. If you have good sleep, but you start having poor sleep hygiene, it will disrupt your good sleep. But if you have poor sleep, you can do all the good sleep hygiene in the world. It's not going to make a difference. That's when you need the cognitive behavioral therapy for insomnia. And you can see that sleep hygiene is part of this CBTI package, but it's not the most important part. It's not the most powerful part. Other strategies like restricting time in bed, reassociating bed with sleep, learning how to relax, challenging unhelpful thoughts, correcting misconceptions about sleep, these are actually more powerful than sleep hygiene. So CBTI is actually the recommended treatment for insomnia. It's endorsed by pretty much every major national and international health organization. So that should be the first line approach to treating insomnia. For other disorders like hypersomnia, sleep disruption in Parkinson's or multiple sclerosis, there is certainly evidence, like I mentioned before, that CBTI is effective in helping improve not just sleep, but fatigue in some of these conditions. And increasingly, there's some interesting research coming out about the circadian impact. Well, circadian dysregulation in things like Parkinson's or Alzheimer's dementia and the beneficial effects of light. We welcome questions, but we're going to ask you to save them till later. I'm now going to turn it over to my colleague, Dr. King.
Hello, everyone. I'm so excited to be here. So I work for the Division of Pain Medicine. I'm a pain psychologist, and I work with an interdisciplinary team, including physicians, nurses, physical therapists, occupational therapists, care managers, and then we also have our medical and pain psychology fellowship. So in order to understand how to treat pain, it's important to first understand what pain actually is. So if we look at the definition of pain from the International Association for the Study of Pain, they describe it, excuse me, as an unpleasant sensory and emotional experience. So you can see that psychology is actually written right into the definition of pain. Most patients coming to see me understand the sensory aspect, but they have less awareness and have received less treatment around the emotional experience of pain. And again, we want to shift from this biomedical perspective into a biopsychosocial treatment model. It's more effective. The definition also has resembling that associated with actual or potential tissue damage. This is an important component to the definition because it highlights that you can have a scan that looks relatively benign and have someone who has high levels of pain. You can also have a scan that looks terrible and they don't endorse high levels of pain. So it's not a one-to-one correlation between what's happening in the body and the experience of the person's pain. This is a vicious cycle of chronic pain. It's important to recognize that there are psychological, cognitive factors, and there are also physical components that contribute to how someone feels. So what we know about chronic pain is that there's a bidirectional relationship between pre-existing psychological factors like depression and anxiety, adverse childhood experiences, trauma, catastrophizing, that can predispose someone to having chronic pain later in life. We also know that living with chronic pain can increase distress and fear and anxiety and catastrophizing, and that the chronic pain population has higher rates of diagnosable depression and anxiety. The reason this matters is that all of these factors sensitize the nervous system, meaning it turns the volume up on pain at the level of the brain. And then we also have the physical cycle that contributes. So if it hurts, a lot of people say, well, I just won't do that, which might be fine for a short-term solution, but a long-term has pretty significant long-term consequences. So activity avoidance leads to progressive deconditioning, reduction in social, recreational, occupational functioning, disability, isolation, which also can sensitize the nervous system. These are the treatments that we use at the pain clinic to help address chronic pain. Pain neuroscience education is sort of that foundation of educating people on what's happening in the body, the mind-body connection, and that movement is important. Motivational interviewing is key when you're working with change. It's change talk and rolling with resistance. Cognitive behavioral therapy, so changing maladaptive thoughts, beliefs, and behaviors around pain. Acceptance and mindfulness-based therapies that really focus on less control of change and more about changing one's relationship with their internal dialogue, whether it be thoughts, feelings, memories, sensations, so it frees them up to engage in behaviors consistent with living a values-based life. Pain reprocessing therapy that focuses on mindfulness, somatic tracking, and threat reappraisal, and then various parasympathetic nervous system activation techniques like guided imagery, hypnosis, and biofeedback. We are very fortunate at the pain clinic to have just a wide variety of classes, talk about a stepped care model. I think this is what it looks like. So we have everything from a single session CBT type class to intensive multi-day interdisciplinary pain programs. And the ones in red are the programs that we bill insurance through, and all of the green options are free. And so I just wanted to put this up. I know we don't have time to go into all of it today, but just to give you a sense of the level of services that we offer. If you're interested in learning more about the programs, you can go to this website. It lists all of our programs, the descriptions, even the dates that we're offering them. Currently, right now, everything is virtual. That may change if insurance coverage changes, but all of the information is on our website. And then I wanted to also highlight that we have a strong research arm, as I'm sure you all know, and these are the clinical research studies that are going on that are actively recruiting for participants. So you'll have this slide to refer to, but you can also go to our website, our research website that has all of this information. And I'm going to go ahead and turn it over to Dr. Craven. Thank you so much.
Thank you. Good morning. I'm Dr. Meredith Craven. I'm the Director of GI Health Psychology in the Division of Gastroenterology and Hepatology. So whenever I talk about GI health psychology, also known as psychogastroenterology or GI psychology, I like to begin with the rationale of why is it important to integrate GI psychology into the care of patients with digestive disorders. Starting off, we know that often medical care alone is not enough. So as has been so well described by the previous presenters, we really want to think about the biopsychosocial model, thinking about the patient as a whole person, the context in which they live and function, and the role that emotions and psychological perspectives and perceptions can have on symptom experience. So for a lot of patients with gut disorders, they continue to experience bothersome symptoms even after first-line treatment. And this often reflects that brain-gut microbiome connection. There's a bidirectional communication pathway that's influenced by stress and other psychological variables. So even if you don't have a digestive disorder, you can still really experience the influence and power of the brain-gut connection. We hear this in our common language. So things like butterflies in my stomach or a lump in my throat. So we know that there are these processes, these cognitive, affective, and behavioral processes that can drive symptom and symptom experience in digestive disorders. And this is what we target through brain-gut behavior therapies. So as the name indicates, brain-gut behavioral therapies are targeting that brain-gut connection. And there are several evidence-based and empirically supported approaches that we can take, including cognitive behavioral therapy and gut-directed hypnotherapy. These are the two that are most often delivered and have the most evidence to support them. When working with a GI health psychologist, your treatment is typically short-term, very much focused on GI symptoms, so helping decrease the intensity and frequency of gut symptoms, as well as increasing coping and resilience. As the chart on the right indicates, we can actually very much individualize a patient's care based off of the processes that are driving symptoms and symptom experience. As mentioned, there is scientific support for both disorders of gut-brain interaction, so something like irritable bowel syndrome, as well as more of these organic disorders like inflammatory bowel disease. Just like any field, there are limitations, but the research support is growing every day and continues to expand, showing how important it is to integrate psychological approaches into the care of these patients. So moving forward, I'll just briefly review two case examples. Discussing the most evidence-based supported treatments, the first, cognitive behavioral therapy. So the irritable bowel syndrome is known as a disorder of gut-brain interaction. There's a dysregulation between the interaction of the brain and the gut, and this is leading to uncomfortable sensations. So for this patient, this is a 25-year-old woman with mixed IBS, and we can see the drivers of her symptom experience. These include cognitions, like what if I'm going to have an accident, emotions of anxiety and frustration, uncomfortable sensations, and behaviors that are decreasing her quality of life and actually potentially leading to more bothersome symptoms. So using CBT, we would challenge and reframe unhelpful cognitions, help her practice relaxation strategies so that she can feel that she is in a safe environment, which is sending signals to the brain, helping the brain dampen down pain signals, and also really target these unhelpful behaviors. So for example, we might do some exposure therapy. So this patient can really face her fears and learn she can go on that road trip and be okay and have a fun experience. The next case example is for globus sensation, which is another disorder of gut-brain interaction. Globus sensation is a feeling like a lump in your throat, a golf ball that you can't swallow. And gut-directed hypnosis is a very effective treatment for globus sensation, helping decrease that experience. So for this patient, we can see the drivers of symptom experience. Again, these psychological cognitive, affective, and behavioral processes that are driving symptom and symptom experience. When using gut-directed hypnotherapy, we're putting a patient in a state of hypnotic trance. So their mind and bodies are very relaxed, and the mind is in a relaxed yet focused mental state. In the state of trance, the mind is more open to suggestions and therapeutic imagery. So for example, I might use the image of an ice cube in this patient's throat and have the patient imagine the ice cube melting so that they can swallow without pain. And again, these are gut-directed hypnosis is targeting these processes that we know influence symptom and symptom experience. Just continuing to highlight how important it is to understand a patient's psychological perspective, the drivers of their symptom experience, as well as the context in which they function. So again, thinking about that biopsychosocial model and the role of psychology in promoting health and well-being. I'll now pass it to Dr. Tanenbaum.
Hello, I am Molly Tanenbaum, and I'm a clinical health psychologist. My research and my clinical work focus on improving health and quality of life outcomes for people with diabetes and on the emotional side of living with diabetes. And I'm really glad to be here today. Living with and managing diabetes is complicated and burdensome. People with diabetes must monitor their glucose levels throughout the day, pay attention to food intake and physical activity, and take medications. All of this can come with an invisible mental and emotional burden, thoughts, worries, and concerns that someone with diabetes may be carrying around with them. And diabetes is challenging to manage on one's own for a variety of reasons. The treatments can be complex and challenging to follow, and someone can do everything the same way on 2 different days and not necessarily get the same results. There are no vacations from diabetes. Someone might not yet be on an optimal regimen for them, and changes and intensification in their regimen or treatment can be stressful. A person's environment might make it harder to make lifestyle changes, like increasing physical activity or adjusting food intake. And finally, what a person is asked to do to manage diabetes and what's recommended might conflict with their own beliefs and understanding about how to take care of diabetes. Because of all of these challenges, much of my role as a diabetes psychologist is to assess and treat what we call diabetes distress, which is a broad term that is defined as the worries, concerns, fears, and threats associated with struggling with a demanding chronic disease like diabetes over time, including its management, threats of complications, potential loss of functioning, and concerns about access to care. And to be clear, diabetes distress is something that we consider to be an expected emotional response to living with diabetes. and not something to be pathologized. And diabetes distress is very common. For example, in type 2 diabetes, around 1 in 5 adults have high levels of distress. And we see diabetes distress with a lot more prevalence compared to those meeting criteria for clinical depression. Diabetes distress has been linked to poorer medical and psychological outcomes. And we care about diabetes distress and want to intervene earlier on, because if we don't attend to feelings about diabetes, someone can reach the point where they feel burned out by diabetes, where they may feel chronically overwhelmed and overextended, and maybe they start to feel like they can't manage it anymore. So how do we treat diabetes distress? First of all, we can assess it. And fortunately, there are several well-validated self-report measures that assess diabetes distress in both type 1 and type 2 diabetes. Once we have identified it, what is important is to normalize the fact that diabetes is challenging and that distress about diabetes is normal and expected, and that they're not alone in how they feel. Attending to diabetes distress involves identifying beliefs, thoughts, and feelings that come up so we can acknowledge them, label them, and address them. And being able to openly discuss feelings about what is challenging and what might be getting in the way can help with perspective taking. People with diabetes may feel powerless, they may feel overwhelmed, and they may be very hard on themselves or feel like they're falling short in managing their diabetes. So part of perspective taking might be helping them build up their sense that even small changes and little things that they're already doing every day are making a big difference, and that striving for perfection is definitely not the goal, but we want to praise the things that they are doing. Focusing on building problem-solving skills can be beneficial, as well as supporting goal setting with realistic, achievable small goals. And just to give a brief illustration of just a case example of treating diabetes distress, I'll talk about a 40-year-old woman who was referred with high levels of diabetes distress and burnout. And through our work together, we identified some of the sources of her distress, as well as barriers to following her endocrinologist's recommendation that she upgrade to newer diabetes technology, which is a closed loop system that would better regulate her glucose levels with an insulin pump and a continuous glucose monitor and an algorithm that connects the two. In the long term, we knew that the system could really help her. But in the short term, it was a lot more on her plate to start a whole new system and deal with the learning curve around that in the context of already having a busy life and a demanding job. Through a combination of normalizing her experience, acknowledging feelings both about the bigger picture of her life with diabetes, and specifically to this recommended change in her treatment, we were able to make space to gain perspective on what it would really mean to try out this new system. And then when she was ready, we worked on making a concrete plan to get it up and running. Thanks so much. I'll turn it over.
Thank you, Molly. I'm Dr. Katie Edwards, and I'm a clinical health psychologist in the Division of Cardiovascular Medicine. Picture of my wonderful colleagues here. So cardiac behavioral medicine services, we treat a wide variety of problems that come into our clinic. I would say probably one of the most common problems is health anxiety and panic. And part of the reason for that, as we all know, is there's a significant degree of overlap between the acute symptoms of sympathetic arousal that come out with a panic attack. So things like shortness of breath, dizziness, increased heart rate, and cardiac symptoms. So what I see in cardiology often are true panic patients who have come to cardiology seeking opinions about whether they may have a cardiac problem. And then also cardiac patients with true cardiac conditions who've developed panic disorder and anxiety around those conditions, and any kind of symptom that they may detect in their body that could signal a cardiac problem coming on. So in cardiology, cardiac behavioral medicine, we offer the same types of treatment modalities that have already been described: motivational interviewing, psychoeducation, cognitive behavioral therapy, mindfulness-based techniques, and biofeedback. And most of the referrals come from these 5 clinics that are listed: general cardiology, electrophysiology, our heart failure and transplant team, our inherited cardiovascular disease clinic, and congenital heart disease. So in cardiology, we are really making an effort to create a stepped care model that can meet the demand of our clinic. We are lucky enough to have a position available for 2 psychologists, and really excited to be bringing on a new second psychologist very soon. So we have these transdiagnostic treatment groups. The color coding here is that the slightly darker ones are the ones that we've already implemented, and the lighter colored blue are the ones that we are putting together and aiming to implement soon. These transdiagnostic groups are run over 6 weeks, 1-hour sessions via Zoom. And I've found that this has been one of the silver linings of the pandemic. Pre-pandemic, it was very hard to get patients to participate in groups in cardiology. Now we have the opportunity to really offer stepped care in a way that we never could before, because groups are very well attended, and we have this wonderful modality for reaching patients who are so much farther away and couldn't necessarily come in for care. So most of the groups follow a similar pattern of offering psychoeducation and self-monitoring of symptoms. We teach behavioral relaxation, such as been so well described by my colleagues, cognitive techniques, and focus on reducing maladaptive behaviors, and then working with making goals, problem solving. And these are sort of a general description of how the groups are structured, but of course, each one tailored to the specific problem at hand. We also have a kind of a lighter, but very important level of care that we're aspiring to build in cardiology, which are the disease-specific support groups. So these are non-billable. Typically, these are the free services, and they're often spearheaded by some of our nurses and APPs who have particular interest with that patient population, and then supported by our psychological team. So in this model, we have actually more groups up and running. We have an ICD support group that meets about 4 times a year, an AFib support group that's just getting started. I teach mindfulness-based stress reduction through a cardiac rehab center and invite Stanford patients to attend. And we have a cardiomyopathy support group and a spontaneous coronary artery dissection support group. So I just wanted to present a few cases, and my colleagues have done such a great job of describing a lot of the theory behind the work that we do. I'm just going to jump in with a couple of interesting cases. One was a 32-year-old female with reactive white coat hypertension who had a history of preeclampsia with her first pregnancy and was referred to me during her second pregnancy for reactive hypertension. It turned out that her hypertensive problem began when she was a teenager with an embarrassing moment at a doctor's office, and was then reinforced afterwards with other doctor visits, and much intensified in pregnancy due to all of the focus and attention on blood pressure. So using a remote biofeedback training device called the HeartMath Inner Balance HRV training device, I was able to teach her a diaphragmatic breathing technique and help her to train herself to really learn to relax, and also learn to let go of what she was trying to do, which was to over control her blood pressure. She was able to improve her skill and eventually got to the point where she could do some breathing in the waiting room and get through a blood pressure reading without too much of an elevated sympathetic response. Second case was a bit more recent. We had a 50-year-old female come in with severe hypertrophic cardiomyopathy. She'd been lost to follow-up for 4 years, and she needed surgery right away and also an ICD implant. She was very fearful and resistant to surgery due to a family history of having both her mother and uncle pass away while they were waiting for cardiac transplant, actually for cardiac surgery. And so what we did was I only met with her for 2 sessions and used a motivational interviewing technique called the decisional balance, where we look at the patient's perceived disadvantages and advantages to taking action or no action, and then talking about those reasons in a way that helps to highlight reasons for change. She's now scheduled to have the surgery on Friday. And then finally, a very interesting case, which I don't have time to really go into, but more of the techniques I'll just point out. This was a patient with a vasovagal response. So I taught her the applied tension technique to help prevent fainting. Then we did some exposure-based cognitive behavioral therapy, which included having her spin in a chair to mimic panic sensations and dizziness and help her use the tools that I taught her to cope during that exposure. And then some worry journaling, worry script and journaling about her health anxiety. So I think I'm going to wrap it up there.
So thank you very much for your attention. We welcome all questions now. We do have some time for questions. You can either ask them now. I see some in the chat in the Q&A, so I'll address those in a moment. But you can also follow up with us individually. We've included all of our emails and phone numbers, so you can do so. One of the questions for me was, what is PAP exposure? I'm so sorry I didn't clarify that. PAP is positive airway pressure. It is the gold standard treatment for sleep apnea. It's not the easiest treatment to adjust to, and so especially for patients who already have insomnia, it can be really, really challenging. And we can use some of these cognitive and behavioral techniques to help people adjust to CPAP more successfully and use it more across the night on more nights. This is especially important because untreated sleep apnea, depending on the severity, has some significant health implications because it involves not just fragmented sleep, but intermittent hypoxemia. It's associated with a number of symptoms, both short-term and long-term, and it is absolutely associated with increased risk for high blood pressure, diabetes, heart attack, and stroke. So treating the sleep apnea effectively, especially in the moderate to severe range, is critical, and the positive airway pressure is the way to do that. There's a question for Dr. Edwards. Do patients need to have a Stanford cardiologist to be referred to the cardiac behavioral clinic? May they be seeing a community cardiologist, someone at Sutter? So, Dr. Edwards, what would you say to that?
I'm sure, happy to answer that. So at present, the patients that are seen in cardiac behavioral medicine are referred by cardiology providers, cardiologists, advanced care providers, nurses. And we do have some external referrals. Now that the word is out that we have this program, there are some internal medicine specialists and others who have referred patients. And typically it's a matter of kind of a case-by-case evaluation. I can think of just one time when we've accepted a case from outside of Stanford, and it was a situation of really a very unique case. So the answer is kind of not really. We try to serve Stanford cardiology primarily. And one of the other things that we do is we very much help patients find external referrals. So that's a common first step with patients whose insurance doesn't cover our services, or patients who we've seen for 4 sessions, 8 sessions, and they just really need more care.
There's a similar question for Dr. Craven. So does a patient already need to be seeing an MD in your clinic to be referred? Could they see someone in the community? So how would you answer that?
Yeah, so I am the first psychologist in the division. I started pretty recently, so I'm still building it up. Right now, I'm only taking referrals from faculty within the division of gastroenterology and hepatology, but eventually we hope to use me as an example of why we should hire even more psychologists, so then we can increase access to care.
And someone had the same question for me. Patients seen by our clinic can be referred by my colleagues at the Sleep Medicine Center, physicians outside of that. They can be self-referred. We do unfortunately, like so many clinics at Stanford, we do have a long wait list. We do our best to get through that. But we do sometimes refer to private practitioners in the community who are qualified to provide these services. These services provide require specialized training. You have to be certified in behavioral sleep medicine, so not just anyone can do it. So we will sometimes refer to folks in the community. There was another question here. Thank you so much, Dr. Spiegel. We know your work well and appreciate it, the hypnotherapy work. Could you discuss these treatments as an opportunity to teach patients how to control their responses to medical illnesses, thereby countering helplessness, anxiety, and depression? I'm certainly, I'll throw it out there. I'm certainly happy to offer my 2 cents. I'll go ahead and offer my 2 cents, and then anyone else can jump in. From my perspective, a big part of helping patients manage their responses to their condition more effectively is helping them understand the condition and correct any misconceptions that in my area always exist. The media has done a nice job of publicizing the importance of sleep, providing some recommendations for how to do that, but the media is a blunt instrument at best. Sleep is not a one-size-fits-all model. And so there are always misconceptions patients come in with that exacerbate their anxiety about sleep and the things they do that seem to make sense but that make sleep worse. Some of the strategies we offer are counterintuitive. So they need education for sure. They need to understand how sleep works because it gives them a greater sense of control. They need to actually implement the strategies. A large part of what all of us do is provide the structure, the motivation, to actually try the strategies we recommend, because the challenge with health psychology is some of the interventions seem trivial, and yet they are incredibly powerful. As we all know, as health psychologists, you literally can rewire the brain when you change how you think on a regular basis. You change what you do. And so part of our job is to help people do that. When people implement these strategies and they see how successful they are, they start to feel less helpless. They start to feel less hopeless. They start to achieve a sense of self-efficacy and self-mastery over the condition. And that just creates, contrary to what Dr. King was describing, a vicious downward spiral. It creates a virtuous upward spiral. I don't know if others would like to add to that.
Yeah, sure. I can jump in. So one of the things that I'm sure all of us deal with are difficult medical diagnoses for which there sometimes are not good treatments, or perhaps there's an anticipated decline. And frequently there's kind of a progression for me with working with these patients where, starting with a lot of education, such as Dr. Barwick was explaining, some of our cognitive behavioral tools to help manage acute distress about the diagnosis or the medical condition. And then really relying on some of these mindfulness and acceptance-based techniques to help patients shift their attention away from the negative part of having a new diagnosis and towards what they really value and care for in making their lives of the highest quality. So there's kind of a 3-tiered approach. And if I'm lucky, I get enough time with the patient to help them through that.
There's another question here. How do you avoid the problems you've discussed are interdisciplinary, GI, diabetes, cardiac, insomnia, anxiety, depression. How do you avoid a whack-a-mole approach, but at the same time address each of these problems without transferring patients from one psychologist to another that could put the patient in a position to mediate among different practitioners? I think this nicely highlights the common overlap between all of these things. The nice thing about what we do as health psychologists, a lot of the techniques we use overlap. You've probably seen more than once: biofeedback, relaxation, changing unhelpful thinking, changing unhelpful behaviors. And so the skills we teach actually translate into a lot of other conditions. And because patients use these skills, get some success, they actually can become more confident in not only managing the condition we're focusing on specifically, but in applying these skills in other contexts to help manage the symptoms of other conditions more effectively. At the same time, I think it's very appropriate if something like, I've certainly worked with patients where anxiety or depression made it difficult for them to engage in treatment, in which case I will refer them specifically to a psychologist who specializes in those things. I will make it very explicit why I'm doing this. I will welcome them to return to working with me once the anxiety and depression is not interfering as much, once they're in a more stable place. But that's my particular approach. What about my colleagues?
Yeah, I agree with that, Fiona. I think, when we think about the comorbidity between mood disorders and the different specialty areas that we work in, the rates are high. And I think it's if depression or anxiety or trauma is interfering with the patient's ability to fully participate in the treatment, then it's a good opportunity to refer them out. And sometimes we catch that and sometimes we don't, because we're not perfect, but it's an open discussion with the patient. And I'm just curious, Molly, we haven't heard from you. Do you have any thoughts on that?
I was just kind of nodding and agreeing with what everybody was saying. I think, there have been situations where I felt like there's something that's so clearly primary that's not necessarily working with me, but maybe it's more directly working on anxiety or depression. And, the diabetes part of it is okay. It's really that they need mental health, more focused mental health treatment. And we're kind of another role I think that we play, or at least, in our, as kind of a bridge to maybe I might be the first point of contact for someone who it's like an entryway into getting more mental health care. And then I can help with facilitating that process. Then there's other times where I've definitely thought, okay, someone is really having a lot of pain, and that's gonna interfere with their, physical activity goals. And so that would be great if that comes first, and then they could come back to me. So I think it really, it depends on the situation.
Dr. Tanenbaum, a question for you. Is diabetic stress a new diagnosis?
That's a great question. So it's not a diagnosis that is in the DSM. It's not a diagnosis that I, put in my list of diagnoses. I think that it's something we can assess. It's something that we can treat, but it's not a separate diagnosis. And I think part of the reason for that is because it's something that we, when conceptualizing living with diabetes as a chronic stressor, that diabetes distress is a natural extension of that. So it's something we're always kind of looking out for and on our radar and want to pay attention to, but it's not a separate diagnosis.
Dr. Craven, a question for you. With the increase in food gluten intolerance complaints in society and significant TV advertising for IBS, does this affect the number of GI patients and also the types of their complaints?
Yes. So in particular, I want to highlight this like food and gluten intolerance. I think a lot of people sometimes get pushed into taking certain tests around food sensitivities, and these aren't always the most revealing. And a lot of times things are just going to come up on these tests, and that doesn't necessarily mean that you should cut that food out. So this is an issue that we are seeing in patients who are trying to very much restrict their diet, take out gluten. And if you actually look at some of the ingredients on these gluten-free foods, it's very processed. So we're not necessarily seeing long-term benefits, especially for those who do not have a gluten intolerance. So we really just encourage patients to eat a healthy, colorful diet. If you do have some sensitivities, see if you can cut that out. But really, we want people to be able to engage in a life that's meaningful and valuable to them. So if you enjoy eating foods, sometimes you need to weigh the pros and cons of that instead of trying to be overly restrictive and controlling.
I know we are out of time, so I think we're going to wrap up here. Dr. Zdalga?
Doctors Barwick, all doctors, thank you so much. This was a record for the efficiency of 5 presenters, and we had so much time for Q&A despite that. Thank you so much. This is just a testament to how amazing clinicians you all are. I feel like I go on talking longer. I know you have patients that are literally waiting for you now, so, and you're all nodding your head. So I'm going to close down. Dr. Harrington, thanks for coming up with this idea. Kathy, Garzio, and you to do this. I want to just extend an invitation, just like Dr. Craven did earlier, Dr. Craven, to come back, for all of you to ever want to come back to your own dedicated sessions. This is so important to us all clinicians. Thank you, everybody, for sticking around, and I hope everybody has a great rest of the week. Thank you again for our presenters for being here, and I hope everybody has a great day.